Hello, and welcome to Grand Rounds, COVID-19 edition, a place where cancer patients can get all their questions answered by medical experts. I'm your host, Jonathan Summers. As we enter another week during this global pandemic, we want to thank all the frontliners, as well as people who are practicing social distancing. Isolation can be difficult, and if you're experiencing any symptoms of depression, please contact a medical professional. Now, let's meet our panel. Today, we have a medical oncologist, Dr. Nieva from USC, and Eileen Fuentes, a community advocate and clinical coordinator at Columbia University. Guests, please introduce yourselves.
Hi, my name is Jorge Nieva. I'm a thoracic medical oncologist at the USC Norris Cancer Center.
And hi, my name is Eileen Fuentes. I am the community advocate for SWOG. I also work as a clinical coordinator for Columbia University Medical Center, where I serve breast and gynecologic oncology patients. I'm also a 11-year breast cancer survivor diagnosed at 34.
Thank you very much. Now let's get into it. For those unfamiliar with cancer disparities, it refers to the difference in cancer outcomes across certain populations. In New York City, there's been twice as many deaths related to COVID-19 in the Latino population when compared to the white population. In Chicago, more than 70% of virus-related fatalities are among African Americans. Do you know why we are seeing disparities in cancer and COVID-19? Eileen, I would love to hear your thoughts on this.
Well, I think what COVID-19 has done is really exposed what's been there for a really long time. Those of us that serve that population that are members of the community know that for a long time, there's been a lot of issues that contributed to that. I feel that the narrative that we're hearing on the news is that we have higher rates of diabetes and heart disease and cancer, but they're not really telling the full story. There's a lot of environmental racism that takes place. We live in the city, we're more condensed, and so there's a lot of different things that contribute to these numbers and these situations. For example, a lot of us live in food deserts, and so there's different reasons why we have these underlying health conditions that make us more vulnerable with things like COVID-19. And so this is just exposing a lot of what those of us that are here in the community are really seeing. For example, a lot of the frontline workers are doing work that they cannot do from home like I am. And so that also puts us in a very vulnerable position.
Doctor?
I think Eileen has an excellent grasp of the things that are going on. What we really don't know is how much each one of those factors contributes in its relative contribution. Of course, there may be some biological differences. It could be that different aspects of genetics among African Americans or Latinos make them more likely to become ill. We know that the hospitalization rate and the ICU rate among African Americans and Latinos is higher than it is among whites. We also know that there are environmental differences. People who are in the Latino community and the African American community have more trouble social distancing. They don't live in large houses. They tend to have jobs that are manual jobs that aren't work from home types of jobs. The method of transportation is more commonly public transit methods. And all of these things contribute to an increased risk of any type of communicable disease. And then there are some differences, as she pointed out, in terms of comorbidities, hypertension, diabetes. All of these are risk factors for worse outcomes. We see here in Los Angeles, where I'm from, that there's disparities depending on which neighborhood you live in. For example, the west side of Los Angeles has actually been hit with relatively large numbers of cases. East Los Angeles has relatively fewer numbers, but South Los Angeles has also many cases, and we're seeing higher hospitalization rates, higher ICU use in the South Los Angeles population.
Thank you for your answer. Now, my second question is, many cancer patients receive care at a community hospital. Do you think that these community hospitals are as prepared to treat their COVID-19 patients as, say, a larger institutions? And should patients be considering going to a different hospital to receive care at this time?
Well, I think for sure that there would be a benefit in going to a private hospital as opposed to a community-based one. However, it makes it really, really difficult because a lot of the private hospitals don't accept the insurance that a lot of our patients at Columbia, for example, we end up being the second opinion because we do accept those insurances. And then also traveling there makes it really, really difficult. One of the advantages of being a clinical coordinator at Columbia University Medical Center is the fact that I was born and raised in the community. I speak the language, and I also have the personal experience as a cancer patient where we can clearly have that communication that I am basically the bridge between the doctor and the patient. There's a lot of doctors that do not speak Spanish. I can speak to the patient. I'm able to translate all of their needs, speak to the family and anyone who's involved in their care. And so a lot of the community-based hospitals, while they might have a primarily immigrant population, they don't have the resources to really provide those types of services. I mean, this is not something that a lot of hospitals have, but I feel really privileged to be I was actually the first hired to do this specific type of job. And so I don't know if that would have been available to me at a community-based hospital. And I just think that for the most part, because those of us in the community have to, you know, whether it's a single mom or somebody that has multiple positions, you don't have the privilege of being able to go somewhere which is across town or that's going to take you 2 hours to get back and forth. And so really what we see is that people go whatever is nearby as opposed to traveling across to a better community or whatever, however you want to identify that. Because I also feel that I should say that in a place like Washington Heights where I work and where I live, there are a lot of advantages of being in a community where there's a lot of people that look like you, whether you have family or not. You have a neighbor that can provide food for you, that come. I mean, many times it's a neighbor that shows up at the appointment. And so I don't want to totally do away with the role that the community plays in terms of the care of the patient, even in, you know, community-based hospitals.
Thank you. Dr. Nieva.
Well, you know, Jonathan, there's very few circumstances where you don't see better outcomes among larger volume facilities. So whether that be cancer, heart disease, or just about anything else in medicine, generally larger facilities, places that have higher volumes lead to better outcomes. In the world of cancer, larger volume centers will have more access to clinical trials, more access to newer technologies, and in general are good things. Here in Los Angeles, you know, we have large institutions both on the public side and on the private side. And so people do have the ability to go to large institutions regardless of insurance status. Now, of course, right now, in the middle of a crisis might be the worst time to try to change your provider. You've got a continuity of care. You have someone who knows you, who can provide care for you. If they can provide care, you know, you're probably well off seeing who you're seeing now. I think the challenge that a lot of people are seeing is, you know, the doctor's offices, lots of places are closed. Many primary care physicians have closed their offices and are not returning phone calls. We've had many patients who basically are just hunkering down at home and aren't having things addressed. They're not having that cough addressed. They're not having you know, that weight loss that's been going on for the last 2 months taken care of. And of course, as a result of preparing for the surge, many hospitals have put off, delayed elective surgery, including elective cancer surgery. And that really, you know, has a lot of people on edge right now wondering, you know, what does it mean when you have a 6-week delay? What does it mean when my surveillance CT scan, which was due in April, has been rescheduled to June because of the cleaning protocols and all the things that are in place. So I think for cancer patients in particular, you have to know that you're able to get the minimum done that you need to get done. Now, some things certainly can be put off. You can put off that scan that you had scheduled 3 months ago to get scanned again in 3 months if everything's going great. But if everything's not going great, if you're losing weight, if you're more symptomatic, that's when you got to get on call with your oncologist and say, hey, things aren't right now. Let's prioritize symptoms. And I think prioritizing patients' symptoms is essential.
That's a great point. Thank you both. Now to our last question, our viewer question. It is, with a shortage of protective masks, who in the public sector should wear them and what kind? Also, why should we ration N95 masks?
I'm always the advocate for the forgotten, right? I don't like to call people, the voiceless, because I think it's more the unheard. At least in New York, 79% of our frontline workers are either Black or Latino. And so I'm talking about nurses, our subway transit drivers, the sanitation workers. And so they too have very much the right to be protected in the work that they do. There's all these hotspots in New York City, and you can see where these frontline workers live is where we have the highest numbers of cases. And so it's not really fair to just say it's for the doctors. It's funny because my past work was in human resources in the hospital setting. And so I know that you're not supposed to use N95 masks over and over again, like we're being asked to do now. And so I think that it's incredibly important for the doctors on the front lines to be protected and also protect those that they serve. However, I do think that it's equally important for those of us that are providing our food, getting us to work, taking care of us, whether it's the cleaning lady at the hospital, everyone actually needs to be protected. And so it's hard for me to prioritize one group over the other when really everyone should be treated equally.
Thank you.
So, I think when we think about masks, you want to think about them having two functions. One is to protect you, and the other one is to protect other people. And just about any face covering will protect other people. So I think if during this time of crisis, if everyone out is covering their mouth.
Even with like a bandana?
Even with a bandana, a cloth mask. If you're going out, you wear a mask not for yourself. You wear a mask for everyone else. And the N95 masks, I only wear them when I go into a room where they might have COVID-19 or they do have COVID-19. I don't wear the N95 mask just in and around the hospital all the time. We try to keep our cancer hospital a COVID-free area, but when there's uncertainty, we'll wear those masks. But when we're out and about, when I'm out of my office, I'm just wearing a paper mask. It's not for me. It's to protect everyone from me, because I could be an asymptomatic carrier. I'm not testing everybody.
That's a great point. I mean, even driving in your car, should you be wearing a mask at that time?
If there's someone else in the car with you, yeah. But I think if you're in your car, there's not really anybody for you to breathe on.
True. We know you're incredibly busy, so we'll end it here. But thank you both for your time and everything that you're doing professionally. Please stay healthy and take care.
Thank you. Be well.
Nice to meet you, Eileen. Bye-bye.
Likewise.
Bye.